I'm Dr. Suyash Sharma from medical team of Zydus. On behalf of Zydus, I welcome you all. We are thankful to MSG for letting us be a part of this academic fiesta today. For further proceedings, I'll hand over the session to Dr. Amit. Over to you, sir.
Thank you, Suyash. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. V. Pretzbecker from Leipzig, Germany. And he's going to lecture us on two topics: current challenges and unmet medical needs in MDS, and new approaches for anemia in MDS. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Sumit Madan, Mr. Ashish Kumar and Team Zydus, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. V. Pretzbecker from Leipzig, Germany, all our discussants who are themselves eminent hematologists and medical oncologists, and you participants for spending your Saturday evening, morning, and afternoon. Tomorrow, that is 8th of October, Sunday, from 11:30 a.m. Indian Standard Time onwards, we have a webinar on horizon scanning in hematology by our guest speaker, Dr. Vishal Jayakar from Kingston Hospital, Imperial College, London. Let me introduce our discussants for the day, and here displayed in alphabetical order. To start with, your Professor Dr. A.K. Tripathi, Professor and Head, Department of Clinical Hematology, King's George Medical University, Lucknow. Dr. Aditya Jandial from Homi Bhabha Cancer Hospital and Research Center, Mulanpur, Punjab. Dr. Akanksha Garg from AIIMS, Jodhpur. Dr. Aryan Jain from PJ Chandigarh. Dr. Bharat Patodia from AIG Hospitals, Hyderabad. Dr. Deep Gala from SGPJ, Lucknow. Dr. Fahima Hassan from SGPJ, Lucknow. Dr. Kripa Bajaj from Basavatarakam Indo-American Cancer Hospital and Research Institute, Hyderabad. Dr. Mona Vijayaran from Sahara Hospital, Lucknow. Dr. Monica Bopanna from King's Hospital, Hyderabad. Dr. Nihar Desai from LTM Medical College and LTMG Hospital, Sain, Mumbai. Dr. Pujita Bai Reddy from Care Hospitals, Hyderabad. Dr. Pradeep K. Reddy from PJ Chandigarh. Dr. Priyanka Chauhan from Apollo Medics Super Specialty Hospital, Lucknow. Dr. Rizwan Akhtar from SGPJ, Lucknow. Dr. Ruchi Gupta from SGPJ, Lucknow. Dr. Sadashivudu Gondeti from Nizam's Institute of Medical Sciences, Hyderabad, Telangana. Dr. Stalin Chaudhary Bala from Nizam's Institute of Medical Sciences, Punjagutta, Hyderabad. Dr. Swati Sinha from King George Medical University, Lucknow. Dr. Urmimala Bhattacharjee from PJ Chandigarh. Dr. Upendra Sharma from Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Varun Bafna from Dr. Bafna's Star Clinic and Hospital, Kolhapur. And Dr. Vikas Talreja from Regency Hospital, Kanpur. Now it's the time to introduce our guest speaker for the day. We have with us Dr. V. Pretzbecker from Leipzig, Germany. Dr. Pretzbecker is Director of the Medical Clinic I, Hematology and Cellular Therapy, the University Hospital in Leipzig, Germany. After graduating from medical school in 1996, he first started medical training in heart surgery. Since 1998, he has been working at the Department of Hematology and Oncology at the University Hospital Carl Gustav Keres in Dresden, Germany. Between 2001 to 2003, he completed a 2-year postdoctoral fellowship provided by the Humboldt Foundation at the Fred Hutchinson Cancer Research Center in Seattle, USA. From 2012 to 2018, he held a position of Professor of Hematology at the University Hospital Carl Gustav Keres in Dresden and was the head of the section of hematology as well as chair of the Medical Ethics Committee of the TU Dresden. In 2015, he was appointed as Trans-Campus Professor of Hematology at the Faculty of Life Sciences and Medicine at King's College, London. Since October 2018, he is heading the hematology program at the University Hospital in Leipzig as Director of the Medical Clinic I, Hematology and Cell Therapy. He is a steering committee member of the SAL group, speaker of the German MDS study group. And today, he is going to lecture us on two topics. The first one will be the current challenges and unmet medical needs in MDS. And the second one is new approaches for anemia in MDS. Well, thank you so much. Over to you, Professor Dr. V. Pletz-Becker.
Yeah, thank you very much for having me. It's a great pleasure and honor also to be part of this meeting here, and also a lot of eminent hematologists actually joining on a Saturday night. That's I'm humbled that this is the case. What I will do, as pointed out before, I will touch base actually two topics. Number one is current challenges and also unmet medical needs in patients with MDS in general. I just see that I opened the wrong PowerPoint presentation, but this will be solved in a second. And number two is focus a little bit on the lower risk MDS part, and this is because I'm sorry, I'm obviously, after 2 years of doing online meetings, I'm not able to open actually the right PowerPoint presentation here, which again is now the case. Here it is. Yeah, because I have actually two presentations, so I thought it's maybe good to split them into two PowerPoints. Okay, so I think I'm not aware whether this is an interactive, where the questions are in between. I mean, honestly, I don't care, whatever you prefer. I'm actually available to all your, let's say, questions at any time, but we can also discuss after the first presentation, after the second, whatever you prefer.
Questions will be said after both the presentations.
Okay, that's wonderful. Good. So let's start with challenges. And again, you are deep dived hematologist, oncologist, you know about MDS, and I think I will not start with the workup and what you do in morphology and dysplasia and these things. So I thought a little bit to pinpoint on the current challenges and what's going on in the field. And I think I started here with something which we really need to work on, and actually we try to work on for now more than 10 years, is actually to establish and define a better frontline care in higher risk MDS patients. So for instance, azacitidine is still the only approved first-line therapy for higher risk MDS patients based on a trial published now more than 10 years ago. And there have been a lot of efforts, combination trials, which basically all failed. And I will not bring them up here. I could and do a PowerPoint kind of presentation, which will bore you, but just recent examples are magrolimab, pavonetistat, but also lenalidomide and other combinations with azacitidine or decitabine have actually failed. And due to several reasons, of course, sometimes the endpoints were maybe considered too optimistic. Sometimes the drug potentially was overrated based on preliminary phase 1, phase 2 data. So what we really need to do in the next couple of years, and I think there are trials running, for instance, the azacitidine venetoclax high-risk MDS trial, the so-called Verona study, which is about to report, I think, next year. Hopefully will give us a new avenue for high-risk MDS patients. There have been actually, just to give you an example, plenty of opportunities.
जे वॉर्डमध्ये शिफ्ट करून गेला आपला सेमीमध्ये काय नाम बुस्टरला आणि ते तानाजीला वरचं रूम पाहिजे तर ते देऊन टाका.
Someone is actually talking while I'm talking. Maybe you can mute your microphone.
Kalpesh, can you please help to mute everybody, please? Mr. Kalpesh, can you please help to mute everybody?
Okay.
Yeah.
Good. So just to tell you, when I basically wrote this review here in 2019, this was actually before the COVID pandemic. These kind of combination partners were, I mean, some of them were explored, some of them also monotherapy. Then actually 2022, 23, a lot of these trials actually failed and drugs have been buried. Some of the examples, for instance, pavonetistat, which looked very good in phase 1, phase 2 trials, but at the end failed. So what we need is, because subgroup of patients with MDS, especially high-risk MDS, become more specific, more personalized, type of mutations, combination of mutations, blast count, type of cytopenia, age, many factors, also immunological factors may play an important role. So we need cooperative trials, maybe for a small subset of patients, just highlighting this is a trial, actually a cooperative group we have founded 10 years ago in the European Union, where we have performed in the past a lot of clinical studies under the umbrella of EMSCO. And for instance, if you are very active in India as well and are interested, we could do also collaborative trials together. We just started an initiative with Australia where we do trials together. So I think it's in general possible also to do studies over several continents. Actually also fair to say that we not only need to improve first-line therapy in high-risk MDS beyond azacitidine, we also need to develop better treatment options for patients failing azacitidine or decitabine, so DNA methyltransferase inhibitors, because the outcome of these patients is really dismal, median survival between 4 and 6 months. Many of these patients are pancytopenic. And again, there have been several efforts, several trials, all of them basically failed. So there is no standard of care. Just to give you a recent example of a trial we published a couple of weeks ago in leukemia. This was actually an AXL inhibitor, bemcentinib, in HMA failure, high-risk MDS and AML patients, and only 20% of the patients responded transiently. So the preclinical data look better than the clinical data, but at least I think it just shows that we need to continue on this effort. There is a development also in the US to get approval of IDH inhibitors, IDH1, IDH2, not only for relapse refractory AML, but also for MDS patients. And you see here, this is an ongoing trial of the French study group, where also the German study group is participating. And these are several cohorts here, cohort A, B, and C, as you can see. So this is cohort C is actually the patients failing HMA-based therapy. So you see that with an IDH inhibitor, IDH1 or IDH2, you can achieve meaningful response rates. Also in patients failing azacitidine-based therapy. So I think this could be one approach for a small subset of patients with higher-risk MDS. The next, I would say, medical need for current but also future development is to develop better and effective strategies for p53 mutated MDS. So we know that p53 alterations, especially B allelic, so a double mutant or del17p loss, are associated with an extremely poor prognosis, with lower response rate to established therapies, higher rates of progression to AML, and significantly shortened overall survival. And this is also true for patients who are eligible for allogeneic stem cell transplantation. So I think that p53 mutation status retains the prognostic impact also after transplant. So the most intensive and most immunological therapy actually we have in our hands for these patients. So there have been several efforts, and I think just to give you some example, this is the APR-246 drug, a drug which was considered to stabilize the mutant p53 protein, and data looked promising, at least for MDS patients. This is a combination AZA plus You see a CR rate of 47%. Again, 34 patients, small number of patients, no response or almost no response in the AML segment. Data have not been published, but are publicly available. The randomized phase 3 study actually did not show a survival or response difference significantly in favor of the combination. So the drug was actually terminated by the company. And the same is almost true for magrolimab, a CD47 antibody. Again, this is data already published now in the JCO a couple of weeks ago with the same response rates. You see 40% P53, and there is an enhanced program by the Gilead company, and which basically just announced that enhance 1, enhance 2 randomized phase 3 trials in P53 mutated MDS and AML were actually closed because of futility reasons and interim analysis. So whether magrolimab will play an important role in the future, especially in P53 mutated high-risk MDS, I think needs to be shown. We also need to advance novel treatment strategies to impact the underlying pathophysiology of low-risk MDS. So currently, low-risk MDS is predominantly treated as a disease where we give growth factors, improve cytopenia, TPO receptor agonists, ESA therapy, luspatercept. I will talk about this the next couple of minutes as well. So yes, temporary benefit can be derived, but there's no disease-modifying effect. And I think this is also because low-risk MDS was for a long time considered not to be a very aggressive disease, but nowadays we know, also based on the molecular workup these patients now get, and we see the complexity of the disease. So just a recent example, and I will show this later on. This is data actually from the phase 2 study with imetelstat, a telomerase inhibitor. You see allelic burden of SF3B1 mutation declines, and the drug is actually very effective also in low-risk MDS. So these kind of therapies, agents, I think, should be further developed for patients with low-risk MDS, and especially for patients with low-risk MDS who have a kind of a higher risk of disease progression or a rather poor prognosis. And when I say poor, I mean many of them can live for years, but mortality, also infectious complications, I think are high in a large subgroup of patients. What we also need is to formulate unified diagnostic criteria for MDS. We had the recent update of WHO and ICC. I think all of them have witnessed that. And there's this discussion on MDS AML, so 10 to 19% blast. Is it still MDS? Is it MDS AML? There are now 2 classification systems in place, which I think is quite kind of a challenge, but it's maybe also a reflection of the polarized world we are currently living in. And so that's how it is, and we need to live with that, and I think take it as a platform for further discussion. So when you see that here, this is the current WHO classification, MDS with defining genetic abnormalities. For the first time, SF3B1 mutation has been introduced, and then you have still MDS, now IB1, IB2, so increase of blast 1 and 2. Instead of EB. I think this is semantically interesting, but does not change a lot. But I think the SF3B1 and also the B allelic P53 is a novelty, which is, I think, an important change compared to the previous one. Also, to establish and systematically validate clinically meaningful response criteria for MDS therapy. So especially in high-risk MDS, we still had the IWG 2006, where actually the response, the CR, is differently defined compared to ELN for AML, and ELN has been recently updated. For instance, the hemoglobin level had to be more than 11 for a complete remission. So meanwhile, and again, this is just hot off the press, there has been an update and of the high-risk response criteria published in Blood a couple of weeks ago, which actually homogenized a little bit the arena for high-risk MDS and AML. So basically comparable response criteria. And this is here for the an effort we did for the low-risk MDS, the revised IWG 2018, where we looked especially at the improvement of hemoglobin levels and also the durability of response, where we think actually this is very important. Also to establish tools to predict and ultimately reduce risk of progression of clonal hematopoiesis. So we know that clonal hematopoiesis per se is a risk factor to develop MDS and AML, but it's not occurring in every human being. It's based on the type of mutation, number of mutation, also the RDW, so the red blood cell distribution width, which seems to play an important role. And there have been now several prognostic tools to predict the development of MDS AML. So maybe we come to a situation in 10 years from now where we have targeted therapies and we can prevent the development of MDS and AML at a very early stage and not at the expense actually of toxicity. So this is all about the challenges. Challenges are there to be accepted, of course, but I didn't want to bore you with a lot of, let's say, data slides, rather to introduce a little bit some considerations where the future research actually should go to. So with that, I switch gears now and will now open the other presentation. So this is all about it. I think you should see it now. So this is now more about low-risk MDS. I think the title is well taken, also by the chair, because I think there has been a lot of development recently, and positive development more in the low-risk segment, and therefore I think it's a good topic to talk about. So what is lower risk MDS? There have been a lot of models, prognostic models. This is shown here. I think the IPSS most widely used, and we have the revised, and then we have the IPSSM quite recently introduced. Important to say that the majority of the clinical trials actually use still the IPSSR. So where we have 5 groups, and some of the high-risk protocols hijack the intermediate group as a high-risk group, and some of them actually in the low-risk trials also take advantage of the intermediate. So the intermediate is a very heterogeneous box with the median survival, as you can see, of 3 years, which I would call it a low-risk or lower-risk patient. But I think especially in these cases, the type of mutation matters, and I will show you in a second that especially SF3B1, I think, is an important denominator of the prognosis of these patients, because patients with an SF3B1 mutation and a ring sideroblastic phenotype, for instance, have a much better prognosis compared to patients without. So, and they can be, many of these patients actually are IPSSR intermediate based on the red blood cell transfusion dependence. So if we look now at the therapeutic algorithm, this looks super busy, but it's actually not, because we don't have so many opportunities. And I will go through this scheme in the next couple of minutes. It's actually supportive care, including iron chelation still as a supportive care, which should be offered to highly transfused patients being iron overloaded. And then I will start with a very small subgroup of patients with lower risk MDS, and those are the ones with predominant thrombocytopenia, so less than 50 or with bleeding, or less than 20 without bleeding. I think we would tend to treat these patients. There have been some efforts with TPO receptor agonists. This is a Trumbopac trial, placebo-controlled. You see 47% response rate. This is the trial we just recently published with romiplostim by our EMSCO group. You see 43% response rate, but also we saw trilineage responses. Neutrophils got up, also patients got less transfusions, so it's a trilineage response which can be achieved with romiplostim. There have been some, data, I wouldn't call it data, but some fears that these drugs actually may accelerate clonal evolution, at least in this trial, and also in others, we couldn't find, or we did not observe this, and we also did an allelic burden measurement at screening and at the primary endpoint, and you see SRSF2 allelic burden did not change in responders and non-responders, suggesting that the drug per se does not extend or expand the clone while those patients are on therapy. So still, there's no drug approved for thrombocytopenic low-risk MDS patients. But I think in the clinic, we use these kind of TPOs for patients who have predominant thrombocytopenia. What about anemia non-del(5q)? So ESA, EPO is the preferred therapy based on EPO levels, just highlighting that I think transfusion burden really matters. So it is actually associated with significantly greater mortality, hospitalization, and inferior quality of life. So I think it's not like going to the gas station and getting transfusions. I think transfusions, patients want to get rid of transfusions. I think that's quite clear if you treat these patients. So therefore, many of those patients are eligible for EPO based therapy, but the majority, if not all, actually fail at the end of the day. So in kind of hypoplastic MDS, you may go for ATG cyclosporin A, very rare occasion. And then, at least in my country, approved is luspatercept for ring sideroblastic patients with low-risk MDS with or without an SF3B1 mutation. Luspatercept is, I think, known to you as a ligand trap to TGF-beta superfamily, which has been shown preclinically, but also clinically, to be a very effective drug to improve actually anemia in patients with low-risk MDS. It actually started all in 2013 in a trial we did with the, at this time, Acceleron company together with Celgene, and then I will actually show you in the next couple of minutes the data by the PACE trial, but also Medalist and also the recent developments of commands. So the PACE study, this is a very busy slide, was a trial we did in Germany for all comers low-risk MDS with a dose titration of luspatercept and just look for a signal. And the signal we actually derived from this trial was that patients with ring sideroblastic phenotype had a significantly higher response compared to patients being RS negative, although a low number of patients actually was included at this stage of the publication. So this led to the Medalist trial, a study for RS positive ring sideroblastic patients only, less than 5% bone marrow blast, and then a 2-to-1 randomization, luspa versus placebo. You know the data already because this led to the approval, a higher response rate compared to placebo, and then there was a long-term follow-up actually of the trial quite recently, where you see that especially patients with a low transfusion burden responded compared to patients with a high transfusion burden patient. And also a quite recent update showed that overall there was a 30% response rate being transfusion-free for patients on luspatercept for 4 months, so which I think is clinically very significant and important. And also patients with a response had a survival benefit compared to patients who did not. So I think this is also an important information when counseling those patients, and side effects are, of course, also something we need to talk to these patients. But fortunately, side effects are pretty rare. Asthenia and fatigue have been reported in a subset of patients. Majority of the side effects actually is going away by itself. So it's not a big deal, but I think you need to talk about this with the patient and kind of acknowledge it if the patient reports it. Also, I just mentioned actually the response rates, which were lower in the patients with high transfusion burden. It's important to say that high transfusion burden patients need to be up titrated with a dose to the maximum approved dose of 1.75 mg per kg, because these patients really benefit from a dose titration and from the highest available dose. So the PACE trial actually had a recent update as well, and you see that this is now for non-transfusion dependent patients, LTB, HEB, but for NTD patients, the response rates were even almost 90% for RS positive patients and almost 50% for non-ring sideroblastic patients, which I think is again showing that the earlier you introduce the drug, the better it is. And this was the actually rationale for the COMMANDS study, a trial which got recently published, and this was the first trial head-to-head comparison luspatercept versus EPO alpha in EPO naive low-risk MDS patients, being either RS positive or RS negative. So both subgroup of patients could be included. And this is actually the patient characteristics. You see that 70% of the patients again had ring sideroblastic phenotype and or were mutated for SF3B1. All patients were red blood cell transfusion dependent, of course. The study actually met the primary endpoint, higher transfusion independence rates, almost 70% compared to 45% with EPO therapy. So significantly superior for luspatercept. And if you look into the subgroup of patients, you see that this was especially striking for patients with RS positive MDS, where in RS negative, the response rates were actually quite comparable, which I think is an important observation. And there's always the debate whether luspatercept is just another EPO, another growth factor. So translational work from this study showed that GDF11 was actually depleted with luspatercept. So this is at screening and week 24, going down, but what remained actually the same in EPO responding patients, which I think is an important observation. We also looked at the modulation of stromal cells by luspatercept and could also show that the GDF11 depletion actually leads to an increase of SDF1 production by mesenchymal stromal cells, and also patients responding to luspatercept had an increase of their SDF1 levels in the bone marrow at the time of response. There's another activin receptor 2A trap, the KAROS, which some preliminary data already exists. You see here that this drug also works in RS positive and RS negative patients. The jury is still out where this drug will go. So the most important question then is, what can we offer in patients failing this kind of therapy? At least in my country, HMAs are not approved, but we know that oral azacitidine is in a phase 3 trial at the moment based on this phase 3 study, that 31% of the patients actually can achieve a transfusion independence with azacitidine, oral azacitidine. So again, this study will set the stage potentially for oral azacitidine in the future. The next trial I would like to highlight here is the IMerge study, and this is again the trial with imetelstat, so the telomerase inhibitor, which was investigated as a second-line therapy in patients with IPSS, low or intermediate 1, relapse refractory to ESA therapy, and high transfusion burden. So at least 4 units of red blood cells within 8 weeks, non-del(5q), and Revlimid and HMA unexposed. This is very important. So this study also has been presented at meetings this year and is currently in press. You see that again, an enrichment for ring sideroblastic patients, 62%, and also high transfusion burden patients, more than 6 units, 47% of the patients. So this is quite an impressive transfusion burden for a low-risk MDS patient population. Also important that these patients, irrespective of their transfusion burden, had normal neutrophils and normal platelets. And this is important because the drug has some cytotoxicity, and I will show you this in a second. So what about the primary endpoint? Primary endpoint was met, 40% versus 15% with the placebo. And it's important to say that these patients actually, if they responded, also had a durable response. You see 16, 24, even 20% 1-year TI rate, which is quite remarkable given the transfusion burden. The response rate actually were the same between RS positive and RS negative patients. So the drug obviously works in all comers and is not restricted to one population. And also important observation was that there was a reduction in the ring sideroblastic cells in the bone marrow upon response, which also was accompanied by reduction of SF3B1, TET, and other mutations. So the drug seems to have a disease-modifying activity. What about changes in hemoglobin? So it's not only a reduction of the transfusion burden or transfusion independence, it is actually accompanied by an increase of hemoglobin levels, striking increase of hemoglobin levels. You see change 3.55 gram per deciliter, which I would say is clinically important, and also the durability of response. Or no disadvantage in case of the number of mutations, also type of mutations, poor prognosis, seem to benefit favorably from imetelstat, and then also a sub-analysis for the third baseline level did not show any disadvantage. What about dose and toxicity? Yes, the dose has to be reduced in many patients because of neutropenia and thrombocytopenia. You see that this is neutropenia and this is thrombocytopenia. %50 have thrombocytopenia, grade 3, grade 4. So it really occurs, but then is getting less in the subsequent cycles, especially also with dose reductions. Important to say is that there were one case of grade 3 febrile neutropenia, yes, but there was no significant difference in bleeding events or infectious complications between the two arms. So the bottom line message here may be, and this is based on a recent FDA approval, because 2 weeks ago, FDA approved actually luspatercept as a first-line therapy for all-comer low-risk MDS patients. It's not approved in my country and in the European Union, but this is definitely now the case in the US, and imetelstat is not approved, but under consideration by the FDA, and maybe the next second-line therapy if again approval is granted. What are other druggable targets in low-risk MDS? Well, I1 beta is of course a marker of inflammation, and there has been already an oral presentation at ASH showing that canakinumab is actually effective in a small subset of patients with low-risk MDS patients, so still needs to be defined. Then there is IRAK4, which is in the center also of the attention because it's a druggable target and upregulated in progenitor cells in high-risk MDS, but also in low-risk MDS. You see the first-in-class here CA4948, which is currently in clinical trials. Then also inflammasome activation in MDS is very common and also associated with a number of mutations seen. We just recently published also a paper showing that inflammation is very heterogeneously distributed in low-risk MDS, and especially del(5q) cases appear to be the most inflammatory. There were two clusters, and actually inflammation in del(5q) MDS was mostly driven by monocytes. So this makes it actually interesting to target in the inflammasome activation, the canonical by specific inhibitors, and this is just one drug which still has this acronym, which is in clinical trials now in low-risk MDS. And you see this is a randomized trial in COVID patients, and this is CRP. So this drug actually reduced the inflammation here quite successfully. The trial did not meet the primary endpoint, small study, but I think in general it showed that it's efficacious. Other drugs are roxadustat, which is a PHD2 inhibitor, and by doing so, it improves EPO production, but also is an anti-inflammatory drug. The phase 3 trial was just recently announced, is actually negative. Then we have improved maturation with pyruvate kinase activators, which are in trials in thalassemia, but also in MDS. So to make a long story short, I think that's where we are. And I think that the era of targeted therapy in MDS is about to start. Luspatercept is a major step forward and now approved by FDA as a first-line therapy. Imetelstat to come, hopefully as well. But we need, of course, more studies and agents and also international cooperation. With that, thank you for your attention, and I'm happy to take questions.
Thank you so much, sir, for that fantastic and wonderful lecture. It was awesome. You had a whole scan of low-risk MDS and what new drugs are there for the low-risk MDS. So we have some Indian colleagues who are going to bother you with question answer session. Are you okay with that? So I request all our discussants to please put the raising sign so that we can start our Q&A session with Professor Dr. V. Pletz-Becker. In the meanwhile, as the questions keep on pouring, I have a case for you, sir. There is a 45-year-old gentleman. He is SF3B1 positive with ring sideroblast, refractory to erythropoietin, refractory to GCSF, refractory to lenalidomide. Luspatercept is not available in our in India. So what would be your next line of therapy if the patient is refractory to len, refractory to erythropoietin, refractory to GCSF, luspatercept not available, but erythropoietin level is less than 500?
Yeah. So can I ask you a question? What was the dose of EPO you gave the patient?
60,000.
60. Okay. And did you give EPO with GCSF or sequentially?
No, with EPO with GCSF.
Yeah. Platelets are normal. Neutrophils are normal.
Platelets are normal. Neutrophils are normal.
Okay. And still the patient gets transfusions on a regular basis, right? Yeah.
Yes. Yes,
yeah.
sir.
Yeah. Okay. So I think if you tried what you tried and it didn't work, and I also have a lot of those patients, I think then you can only go for a kind of experimental therapy. Of course, number one is a clinical trial. If available in your country, then of course I would prefer a clinical trial for such a patient. If not, then one may consider, and again, these are old data and maybe not valid anymore, but nobody knows. This is a kind of single patient. So all I'm saying is thalidomide, although the patient had lenalidomide already, but I think thalidomide in a low dose, 50 to 100 milligram per day, is worth trying. The second thing is I was part of a translational paper in Science Advances quite recently, where looking for vitamin B5 as a very important This was a collaboration with King's College we had in London. Vitamin B5 being a very important cofactor for spliceosome mutated ring sideroblastic MDS. And I can tell you, I treated a patient with vitamin B5, the same patient like you. When I say treated, I mean, it's a vitamin, so you can basically get it. And the patient seems to stabilize his blood counts. I'm not saying that this will help your patient, but there's at least a rationale. And if it works, please let me know. Then we can publish both cases together.
Thank you, sir. That was excellent. Dr. Arianjan, your question, please.
Yeah. Hello, sir. This is maybe an extension of Dr. Amit's case. So in a low-risk MDS patient who is young and fit, we know that whatever the therapies we offer, they do have a limited response rates, and often they fail with the passage of time. So instead of waiting for them to become transfusion overloaded and then considering them for an allogeneic transplant, like what is your algorithm, particularly in, say, who are less than 40 and we have reasonably ruled out a germline predisposition?
Yeah, that's a very good question as well. So I think my strategy is transparency, with the patient about what allogeneic stem cell transplantation means. And again, I mean, I'm also doing a lot, and I have done and still do a lot of transplant. So you both, and you all know that transplant, if it works, it's fantastic. Patient is feeling better after 3 months, 6 months, potentially, if the patient is 40 or 45, can work already, but it can be also catastrophic. And after 4 weeks or 2 weeks, got GVHD, and the patient basically is almost dead. So I think it's a balance between the chances and the risks. And what I'm doing, and we will actually just, and as I have a second patient, 35 years old, the same like the case before, where nothing worked, even imetelstat didn't work in a clinical trial. So we will now transplant this woman. But I was very transparent to her and also to her husband and said, listen to me, it could be that there's a high likelihood that you will be at home at Christmas, but there's also a 10% likelihood that you won't. And if that's okay for you, I think then that's fine. And this is especially for patients where anemia and red blood cell transfusion burden is the major burden. I mean, I would talk different to a patient who has severe thrombocytopenia at the same time, bleeding events, or who has severe neutropenia at the same time, and has actually already 2 severe infectious episodes, almost being at the ICU for a couple of days, something like this. So therefore, I think it's a balance, and you have to talk to the patient in a very serious and transparent way.
Any other question? Yeah.
If am I allowed to ask a couple of more?
Please go ahead. Please go ahead.
So this is regarding high-risk MDS patients where you are giving them HMA and they are profoundly thrombocytopenic and or neutropenic. How comfortable you are in kind of combining a TPO-RA or a GCSF in addition to HMS, if at all?
Very good conversation. Yeah, I think the TPO is, to me, it's out. I mean, there have been several attempts with eltrombopag. There's a randomized phase 3 trial we published 2018 in Blood, which basically even showed that the TPO-AZA patients got a little bit worse with regard to the survival for unknown reasons. So there's no evidence. For the GCSF, there is a small phase 2 trial from the Czech study group. You may check, it was recently published, I think, Leukemia Research. I very much like this study from the very beginning because it's a smart an easy trial, and it showed actually superiority. It was a small study, I think 30 patients in each arm, but it showed a significant improvement in CR rate. So if I would have a patient here, and let's say a patient not eligible for transplant, but fit 76, whatever, and you really would like to go for the best available therapy, I would rather put the patient onto a combination of AZA G-CSF in the absence of any other opportunity.
Thank you, sir. And sir, one last question. Do you routinely screen for, say, DDX41 in elderly MDS patients? And
Yes.
And does that have a connotation, except for the discussion which you have with the patient, does it impact your treatment choices?
Yeah. So, I mean, there have been now more papers on DDX41 than patients, just as a little joke, but you know what I mean. So I think it's a rare abnormality, but it's rare but common, and we see it more and more often. As you know, it's linked with the more benign nature. I mean, when I say benign, indolent, let's call it indolent nature of the disease. Many of those patients are male, are beyond the age of 70, and also have a favorable response rate to azacitidine. So does it affect my treatment choice? Well, I think if the patient is high risk and is below 70, I would favor transplant. If clinically fit, if the patient is beyond that, I would of course go for AZA plus. But of course, it requires a counselation of the family for checkup, genetic checkup. I think that's the consequence. But in general, I think the patients mutated have a rather good prognosis.
And one last question, if I'm allowed to. So after how many, say, months or weeks of therapy, particularly in these low risk MDS patients, you would say that, okay, this, say, a EPO is not working or a LEN is not working? Like, when do you say, is it 3 months, 5 months, 6 months? I mean, and what is the basis of that figure?
Yeah, as a rule of thumb, 6 months.
Thank you.
Any other question, Dr. Arvind? Okay, thank you, Dr. Rinjain. Dr. Aditya, your question, please.
Good evening, Dr. Uwe. My question is actually an extension to what Dr. Amit and Dr. Arihant discussed. So, do you, in a patient who is like young and who has been diagnosed as low risk MDS and treated with multiple agents, including EPO, luspatercept, or other agents, do you support, or what are your views on the paradigm where we repeat the bone marrow examination and reclassify these patients in future? Do you do that in clinical practice? And does a low risk patient, we talk about the risk of progression or overall survival for a patient with low risk MDS to be like close to 10 years or 8 to 10 years? And does a dynamic assessment paradigm applies in clinical practice?
Yes, it does. And I think for those patients, I think before we talk predominantly about a patient with RS positive MDS and an SF3B1 mutation, which the majority of have a very good prognosis. When I say very good, is they have worse prognosis compared to the general population, but a rather good. But in general, I would fully agree with what you said, and I would also go for dynamic assessment, because some of these patients may acquire secondary genetic events. It's rather uncommon in SF3B1 mutated patients, but also in them it can occur. So to make a long story short, in order to decide or not to decide when and how to transplant, I would use the IPSSM, the molecular IPSS in a given patient, because it's also important for the patient, to to balance the potential risk of transplant with the potential gains with regard to the natural course of the disease, which I think is much better reflected in low-risk MDS patients based on the IPSSM.
And thank you. And my second question is in the context of luspatercept. So for low-risk MDS, as you showed, it has shown excellent outcomes in patients who have ring sideroblast phenotype. So my question is, like, it is a costly drug when we talk about like its routine use in lower middle income countries like India. So do you like check the levels of TGF beta or any other biomarkers that can predict the response, or that can show that this patient or particular patient is not going to respond?
Yeah, there's no such data available. All I can say on a very, let's say, clinical perspective, patients, as I said before, with high transfusion burden, so 2 units every 2 weeks, they tend to not to respond. And also, especially if they are non-RS positive, so RS negative patients. So let's say a biomarker-driven approach could be to put a patient with RS positive, low transfusion burden MDS on luspatercept, because these patients, most of them actually respond pretty well. And all the others, yeah, depending on alternatives, you may consider or may consider not, but the responses are in general, and I don't want to generalize here, but are in general worse compared to the RS positive patients.
And if I'm allowed to ask one more question. So you in your algorithm, you clearly mentioned the role of serum EPO in deciding the therapy in low risk MDS. And while treating or while managing thrombocytopenia, what about the role of serum TPO?
Yeah. So there was some data like 8-9 years ago suggesting that TPO level of less or more than 500 was actually associated with a better response. I mean, lower TPO levels were associated with the higher response. In the study I mentioned, we published in leukemia last year with the romiplostim, we looked also for this and we could not find an association with TPO levels. So in general, I mean, there was a trend, like TPO levels of more than 500 patients tended to respond less, but it was not a black and white thing. So I would check it potentially, but treat.
Thank you.
Thank you, Dr. Aditya. Dr. Upendra Sharma, your question, please.
Thank you, Professor, for that wonderful talk. For those patients of MDS who are responding to HMAs, so what is the strategy if the patient is responding? So how long you have to give that HMA, and any strategy that we can reduce the dose for those responding, or we can increase the duration from 4 to 5 or 6 weeks? And it's because some of these patients, they have a good response to HMA, and they ask us, so how long we have to continue this, whether we can reduce the dose or prolong the duration.
Unfortunately, there is no data for the best strategy. So I think there is one rule of thumb, and this is never stop it. I mean, if you stop it, the disease will come back in the next 3 or 6 months. So if you completely stop it. So what's the compromise? Compromise number 1 is to go from 7 to 5 days. I think that can be done safely. So instead of 7, going for 5 days. And then the next question is the interval. The maximum interval I would accept is 6 to max 8 weeks. But I would say 6 is maybe the optimal. So 5 days every 6 weeks, that's a good maintenance strategy.
Thank you. Dr. Amit, can I ask one other question? So any role of oral ESA in MDS patients?
Yes, but in low risk MDS patients, and not as a switch or maintenance in high risk. But now you have decitabine approved, at least in my country. The oral decitabine is now approved for AML. So I don't know what's the accesses to oral decitabine in India, but you also have the oral azacitidine as a maintenance in AML, the ONUREC. You know, it's of course these are of course expensive drugs, but in a given patient you may consider to switch from subcutaneous to oral. But again, this can mean that you have reimbursement issues with the insurance company.
And any role of venetoclax in MDS patients?
You mean the oral azacitidine or
Oral
venetoclax?
venetoclax.
Yeah. Venetoclax. Yes, there are trials now with the subcutaneous AZA plus venetoclax in high risk MDS. I'm not aware of trials with both oral combinations.
Thank you.
Thank you, Dr. Upendra. Dr. Akanksha Garg, your question, please.
Thank you, Professor, for the nice talk. So I wanted to discuss one case. I had a patient with hypoplastic MDS, and I started him on immunosuppressive treatment. But he had issues regarding ATG acquiring, and because of the expense, he could not afford that. So I started the patient on cyclosporine with the eltrombopag combination, and he had the platelet counts were maintained, but the anemia was persisting, and he had a very high transfusion burden of almost once in 2 weeks.
Yeah.
So then what happened was I thought of giving luspatercept as a just as a trial, and to my surprise, after a single dose, his hemoglobin improved from 6 grams to almost 9 grams. So now I'm thinking whether how to proceed further, and what should I taper off the immunosuppressants and just continue him on luspatercept, and maybe taper off the luspatercept as well later on. So what are your comments for this case?
Thank you very much for the very nice case. Before I answer, 2 questions. PNH clone was excluded?
Yes, PNH was absent.
Okay.
PNH was
and number 2, did you do a molecular workup for this patient?
Yeah, it was done initially. So there were no other markers that were found, and in the cytogenetics, he had a 13q deletion.
That's very common. Actually, that's very common for a let's say hypoplastic low-risk MDS.
Yeah.
So I think number 1, I see like these 13q patients. I would say I see 1 every second year. Yeah. So it's a very rare disease, and I guess also your case is not like you don't have 20 of those patients. I guess you have, this is a single. So it's very rare. And the 13q, I remember one patient with the 13q I put on the oral AZA BMS Celgene trial, randomized, but the patient was actually on placebo, but had a spontaneous remission. Spontaneous. Okay. Even the 13q. So something happened. I don't know what happened. The 13q vanished or almost disappeared. Just it's not your case, but I tell you, these hypoplastic immune-mediated cases maybe you just did the right thing. Basically you immunosuppress the microenvironment, and now you push the differentiation. So it's serendipity. So what would I do here is if the patient can afford luspatercept, if it's okay, I would definitely continue the combination, the triplet, for 4 months and see what's going on. And I think then I would rather discontinue the immunosuppression first. Okay. So the cyclosporine, followed by a trombopag, followed by luspatercept. But this is gut feeling. Yeah.
Okay. Thank you so much.
Pleasure.
Thank you, Dr. Akanksha, for sharing a wonderful case. Dr. Deep Gala.
Thank you, sir, for this excellent overview. I have 2 questions actually. For when will you consider using lenalidomide apart from MDS with del 5Q? And at what dose, sir?
So there is actually super evidence that Revlimid works in non-del 5Q. There's a phase 3 trial, but the company Celgene did not take it to FDA due to reasons I don't understand. But that's how it is. So there's beautiful evidence, and the response rate was 35% in non-del 5Q patients. Again, cytopenia, neutropenia, and also thrombocytopenia can occur, but that's can be easily managed in the majority of the cases. In the US, actually, a lot of colleagues of mine use lenalidomide as a second-line therapy, sometimes after in patients failing ESA. So do I use it in my country? No. And the reason for this is it's rather expensive. It's not approved. And insurance companies in Germany are rather strict, especially in that case. So would I use it in a patient with no alternatives? Yes, I would. But if I would, I would definitely apply at the insurance company to get it reimbursed before I prescribe it.
Thank you, sir. And I have another question, sir. For patients with MDS without ring sideroblast, so what will be your preferred choice to start the treatment? Will it be EPO or will it be luspatercept?
Yeah.
As you clearly mentioned, the earlier you introduce luspatercept, the better it is. So
yeah, there's a famous movie about India, won the Oscar. It's the 1 million. What's the name? 1 million.
Slumdog Millionaire.
Yes. Well, yeah, Slumdog Millionaire. And this was my. I was fascinated by the movie. I must tell you, in of course 2 ways. But this was my sensation here now, because this is the $1 million question. You are asking, because it's. If you look at the data, it's basically the same. The response rates are the same. The durability of response seems to be better with luspatercept, but again, small data set available. So what would be my consideration? Number one is consideration is the transfusion burden. I think if the transfusion burden is super low, basically 1 transfusion and so on, well, I think it's maybe still okay to start with EPO therapy and then wait for the response. On the other side, if you start with EPO, there's limited data for the efficacy of luspatercept in non-RS patients failing EPO therapy, because the patient then would subsequently be considered an EPO failure patient. Number 2 is, what's the comorbidity? What's the clinical status of the patient? Is the patient a fit, mobile patient, or a patient who basically wants to stay at home and self-inject? Because with EPO, you can self-inject. With luspatercept, at least in my country, patients need to come to outpatient department and get luspatercept as a drug. Then it's of course the mode of injections, 3 weeks versus 1 week. So I think we still need more data, and there is no super easy answer to that. I think the approval, to me, doesn't mean that every patient should get it. The approval means that we have a choice. Do I have more evidence how to make this choice best? No. I think the evidence I presented to you is what we have, and we need a little bit more to better understand who may benefit the best.
So just the extension of the question. So if the patients, they have failed EPO and they have high transfusion burden, and you consider to start them on luspatercept, so what will be the dose that will start with?
The dose will the one actually being approved. So you always have to start with the 1 milligram, 1 mg per kg. But in these patients with high transfusion burden, you always need to escalate, irrespective of what's going on. Always escalate to 1.75 to the maximum dose. In all the other patients, low transfusion burden, you may end up with 1 mg per kg being enough to maintain the patient transfusion independent.
Thank you, sir.
Thank you, Dr. Deep. So we have some questions from the audience. Dr. Nikhil wants to know that he has a patient with MDS with 5q deletion who has got no response to lenalidomide after 1.5 years, or loss of response to lenalidomide after 1.5 years. And obviously there is no response to erythropoietin also. So what would be your next line of management for this case? A person who has lost response to lenalidomide after 1.5 years of therapy and no response to erythropoietin.
Yes. Check the bone marrow again, look for disease progression, and also look for the presence or absence of P53 mutation, because many patients actually at the time of loss of response, they acquire P53 mutations. If so, the patient can be considered a higher risk patient, even though the bone marrow blasts may not exceed 5%. But in the case of P53 mutation, I think the patient is at a high risk to develop high-risk MDS and even AML. So if there is a need to treat the patient, I would rather then switch. Again, we talk about high-risk MDS or P53 mutated to azacitidine. If this is not the case, so if patient has no P53 mutation, still del5q, single del5q disease, no excess of blast, and then you can actually retry Revlimid. You can re-expose to Revlimid. Some patients, 20% of the patients actually may achieve a second round of response.
Can we add GCSF along with that, sir?
No evidence.
And does luspatercept help here?
Has not been investigated appropriately to make it, to basically say it may work. So if you have the opportunity to try it and publish it if it works.
Thank you, sir. Another question from Dr. Nikhil. Should EPO always be given in combination with GCSF for optimal response even with normal TLC?
I wouldn't. I would go for EPO 60,000 over 4 months as a first-line therapy in all cases. And only if the patient does not respond, you may subsequently add GCSF for another 2 months and see what's going on. Roughly 20% of the patients, especially the ring sideroblastic patients, can be rescued by the addition of GCSF.
Another question is for patients who have got 5q deletion and those patients who have got RARS, refractory ring sideroblast, what is the dose of GCSF what we are using in case of RARS, in case of 5q deletion, in case of non-5q deletion, MDS?
Together with EPO, you mean? Or...
Together with EPO.
So it's actually I actually go for granoside 13, which I think is 13 microgram. So I go for a very low dose given concomitantly with EPO at the same time. It's not to increase the leukocyte or the neutrophils. It's so patients can develop a mild leukocytosis, but it's not about to increase neutrophils. It's just to stimulate the erythropoietic maturation with the concomitant administration. So I go for the lowest available single dose.
So that's all. Thank you so much, sir. And any other discussions? Have any other question for Dr. Prenz-Becker?
Sir, can I ask
yes,
one more
please go ahead,
question?
Dr. Deep. Yeah.
So, in patients who have failed azacitidine, do you try using becitabine for them?
Only in case they have AML, but there is limited evidence. So like 10-15% of the patients can benefit from a switch, but only transiently. So I would rather than, if the patient has AML, I would rather switch. Yes, I would, but then combine with venetoclax.
So, fine. So anybody else, any other question? So I finished all the questions from the audience and there are no more questions. Any discussions want to ask any question to Dr. Prenz-Becker? Well, in that case, sir, thank you so much. Or Dr. Aryan has a question. Dr. Aryan, please go ahead.
sir, your take on androgen in MDS patients. And we know that androgens sometimes do work by telomerase elongation, and we are also talking about telomerase inhibitors in MDS. So do we say that MDS are a heterogeneous disease, and maybe it's the subgroup which works, one subgroup works in a particular drug and the other one in the other?
Limited evidence, limited data, no control trial, not available, at least, I mean, it's available kind of my country. Danazol, for instance, is also used. There's a recent phase 3 trial in myelofibrosis. You may have seen it, the momentum trial with momelotinib. So danazol works in also in MPN. It works also in MDS. Yes, try it. Is there any biomarker predicting response? No.
Thank you.
Thank you, Dr. Aryan. So any role of interferons in the low-risk MDS?
No.
Thank you, sir. So I finished all the questions from the audience, and there are no more questions from the discussants. Well, thank you so much for that fantastic and lovely lecture. And what a wonderful discussions. Thank you for being there this Saturday, afternoon for you and evening for us. And have a great day, sir. Thank you once again for a fantastic, fantastic lecture. Wonderful discussion.
Thank you very much. Have a good day.
Bye-bye.
Bye.
Thank you, Dr. Amit. So on behalf of Zydus, I would like to thank Dr. Becker for excellent session and for lecture and discussion per se. Thank you, faculties. Thank you, delegates, for attending the same. I'd also like to thank Dr. Amit Khurana, sir, and Mumbai Hematology Group for organizing this evening meeting per se. Thank you, everyone. Thanks.
Thank you, Dr. Suhash. Wonderful discussion. And thank you, Zydus, for sponsoring this event. Thanks a lot.
Thanks.